Welcome everybody to the Kirby Institute seminar series. My name is Philip Keane. I work in the HIV Epidemiology and Prevention program at the Kirby Institute, and I'll be chairing today's seminar. Today's seminar was to be chaired by Dr. Ben Bavington, and Ben regrets very much that he's not able to chair today, but unfortunately he's unwell. But I'd like to begin by acknowledging the traditional custodians of the lands on which I'm on, and some of this, or those of us in Australia, gather today, and to pay my respects to their elders past and present. Today I'm at the UNSW campus, so I'm on the lands of the Badjadgul people of the Eora clan. And I extend my respect to Aboriginal and Torres Strait Islander people joining us here today, and to their elders past and present. So just some housekeeping to start off with. The format for this seminar is that we're going to have three presentations. I'm going to do introductions for each of the three presenters, but all at the beginning, and then each of our three presenters will, when they finish, just hand over to the next presenter. There is, for questions to our presenters, please enter questions into the Q&A box progressively as we go, and I'll be reviewing those, and we'll be working through the questions at the end. We will be leaving time at the end for questions, and we welcome them. So I'd like to start by introducing Dr. Stephane Wen-Wei Ku. Stephane will be talking first. Stephane is the Director of Infectious Diseases at the Taipei City Hospital in Taipei in Taiwan, and he is currently working as the Director of the Division of Infectious Diseases, and also is a clinical researcher with the Treat Asia at the Taipei Veterans General Hospital. His research interests include HIV and STIs, chemsex and the sexual well-being of LGBTQ communities, and he has been actively involved in PrEP implementation in Taiwan. After Stephane will be welcoming Dr. Carol Strong, and Carol is an associate professor at the Department of Public Health at the National Cheng Kung University in Taiwan, and her areas of study include adolescent health, sexual health in men who have sex with men, and behavioural interventions. And then our third speaker, who is joining us from London and staying up very late, is Dr. Isaac Yen-Hao, who is a research fellow at the Department of Public Health, Environment and Society at the London School for HIV. I forgot what the H is, but also tropical medicine, I think, in the UK. And Isaac is a Taiwanese physician scientist who's dedicated to combination HIV prevention, particularly the implementation of PrEP worldwide. He currently works as a postdoctoral research fellow, both at the London School and the University College London. So it's my great pleasure to hand over, first of all, to Stephane.
Thank you, Philip, for the introduction. Good afternoon, everybody. It's my honor to talk today and share with you the experience as well as the challenge we have while implementing PrEP in Taiwan in the past few years. And this is my disclosure. So to start, this is the trend of HIV incidence in Taiwan. And the incidence has been steadily increased since the first case was found in Taiwan in 1984, with a concentrated epidemic mainly among GBSM. And there was a peak in 2005, mainly driven by HIV infection among people with injection drug, which was quickly brought down by needle syringe program and the opioid replacement therapy. Unfortunately, we started to see the incidence going down from 2018. And we do believe it's because of combination of different strategies, such as improving the second and third 90 score, as well as introducing HIV self-tests and our topic today, PrEP. So PrEP was first and officially introduced in Taiwan in 2016. Taiwan AIDS Society is shown on the very left side, the orange circle. It's a medical society composed of ID physicians and HIV case managers. At that time, we drafted the first version of National PrEP Guideline in May, and followed by the approval of Truvada for PrEP by Taiwan FDA in August. And then Taiwan CDC launched its first pilot one-year PrEP project in October, which was also the first government-funded PrEP program in Asia back that time. And throughout the program, it provided PrEP to around 300 participants in a year. And then the CDC implemented another expanded project between 2018 and 2020, and more than 2,000 participants were enrolled. Recently, the Taiwan AIDS Society, we have been drafting the third version of national guideline, hoping to add TAF-FTC and long-acting injectable to the recommendations. And meanwhile, our CDC rolled out their PrEP 3.0 program in 2021, aiming to steadily scale up PrEP use, and it's still running nowadays. One unique point for PrEP implementation in Taiwan is that we kind of introduced on-demand or event-driven PrEP pretty early. In 2018, when we revised our PrEP guideline, the second version of a PrEP guideline, we added the recommendation of event-driven PrEP use for GBSM as well as transgender women, given there was new evidence from the IPREGATE study. And we came up with many workshops and also educational material teaching the case managers, the doctors for prescribing and consulting with clients about on-demand PrEP, and also making these like educational clips to explaining to the actual users the do's and don'ts about event-driven PrEP. So this is the one you see here. It's made by our Taiwan AIDS Society, and you can see that from the YouTube. And this is the PrEP status quo in Taiwan, according to the website PrEP Watch. There are three major rules so far to access PrEP in Taiwan. So first is from the CDC PrEP 3.0 program, and you can get Truvada with a cost of around 60 Australian dollars for 30 tabs. However, the criteria for being enrolled to the CDC program is a little bit strict. You need to be younger than 36 years old, commercial sex workers, engage in chemsex or in a serial discordant relationship to be eligible. Otherwise, you can only get PrEP either buying Truvada out of pocket with a cost around 200 Australian dollars for 30 tabs, or buy Thai or Indian generics from the many suppliers online with the help of PrEP-friendly doctors, but with 1/5 cost of the brand name TDF-FTC. So it's much, much cheaper. So in order to understand how PrEP was accepted among GBMs, we actually we worked with Sean and Alex from Hornet and also Adam Moore from La Trobe, and conducted a serial online surveys by the end of 2017, 2019, and 2021, in order to evaluate the proportion of PrEP awareness, willingness, and actual use in participants enrolled from one of the most popular social dating application for GBSM in Taiwan, which is Hornet. So in the following, we're going to share the result from this series survey. These were our advertisement posted on Hornet, which when same-sex marriage was legalized in 2019, as you can see on the left side. And also because of COVID, the Taiwanese border remained closed. So a lot of people went for mountains and beaches. So that's how we framed the advertisement in 2021, showing on the right side. So these surveys were similarly conducted by convenience sampling and include questions regarding basic demographics, HIV serostatus, risk behaviors, PrEP awareness, willingness, and current PrEP use and its mode of use. So in the recent 2021 survey, more than 1,700 respondents reported HIV negative and untested or unknown status were used for these analyses. So among these respondents, 3% reported daily PrEP use and 11.5% reported event-driven PrEP. So compared to 3% versus 7.4% in 2019 and 1.3% versus 1.7% in 2017, there is a growth of event-driven PrEP user in the past 4 to 5 years in Taiwan. So we asked them why they choose one PrEP regimen over the other. So the top 3 reasons for people choose event-driven PrEP over daily was event-driven PrEP being more affordable, or the users having less frequent sex, or the users being able to plan on having sex. On the other hand, people choose daily PrEP was mainly because they can predict when they to have sex, and or they found daily PrEP easier to remember, and they believe daily PrEP has better protection. If we look at the PrEP willingness and actual use in different age groups, those aged 31 to 50 actually do better than age 26 to 30, and even much better than age 20 to 25, regardless of the proportion of people actually taking PrEP showing showing either orange, or people not taking PrEP currently but are willing to use PrEP in the future, showing blue. And for those who reported not being willing to use PrEP in the following 6 months, the major reasons are they have difficulties accessing to PrEP, or the cost of PrEP is still high for them. And simply people reported they don't have that frequent sex, so they are not willing to use PrEP. So finally, we'd like to show you very quickly the trend of PrEP awareness, willingness, and uptake found in the past 3 surveys from 2017 to 21. So in both groups where people currently taking PrEP, shown in the orange line, and people not taking it, shown in the blue line, there is a significant increasing trend of PrEP awareness from 2017 to 2021. Regarding PrEP willingness, there's an increasing trend, as well as a significant increasing trend among people not currently on PrEP, but not for those already taking PrEP now. And the actual uptake of PrEP also has a significantly increasing trend from 2017 to 2021, as you have seen from previous data. And we would also love to see the risk compensation and how it was evolved throughout the past a few years. And interestingly, although there look like an increasing trend in both current PrEP users and non-PrEP users, it's actually in the non-PrEP users shown in the blue line here has a significant increasing trend. And for post-exposure prophylaxis or PrEP use, current PrEP users actually have a significant decreasing trend. And on the contrary, non-PrEP users have a slight yet significant increasing trend. So finally, I think everybody is very curious about how the STI diagnosis was evolving. So we actually asked the question in the past 12 months, have you been diagnosed with any sexually transmitted infections? So this is a self-reported answers. So in both groups, in current PrEP users or non-PrEP users, the proportion of self-reported STI diagnosis do not show any increasing or decreasing trend throughout the past few years. So this is pretty much the summary from my part. So PrEP uptake has been steadily increased among GBSM in Taiwan, especially taken with an event-driven schedule since the CDC implemented its first government-funded program in 2016. However, there are still great gaps between the demand and accessible and affordable supply of PrEP for key populations, especially among younger key populations in 2021. So I guess we just never prepped enough and we really need to do more. And I'll pass it to the next speaker, Carol. Thank you.
Hi. Hi, I'm Carol, and I'm a behavior scientist. I'll be sharing PrEP uptake. Let me minimize this. PrEP uptake, adherence, and Yen-Hao's application. So like what Stephane was talking about, a lot of discussion about PrEP in Taiwan is on event-driven dosing regimen. This is not an easy dosing regimen to start with. You need to anticipate when sex will happen in 2 to 24 hours before sex, and you need to remember to take the after pills. So you can imagine that it's very likely to miss the pills, but missing pills may cause insufficient protection. So this is why we're interested in this regimen so much. But there's also benefit for this regimen. For example, number of pills are needed for this event-driven regimen are much fewer than daily regimen. So if you want to save up, you might be likely to choose this dosing regimen. So in Taiwan, when both daily and event dosing regimen were recommended in the guideline, it is like a lot of people who are on PrEP actually prefer to use event-driven dosing regimen. However, if you look at the cost of PrEP, the cost is similar to UK, but the GDP in Taiwan is a bit lower or much lower than UK. If we compare to a country with similar population size, such as Australia, you can see that the coverage of PrEP remains really low in Taiwan. So in Australia, it's about 51,000 people on PrEP, and in Taiwan, this year, the estimated number is 4,000 people on PrEP. So today I'll be talking about 3 issues. One is the switches between dosing regimen among GBMSM. So if you were provided with the option of event-driven dosing regimen and daily dosing regimen, would you choose to switch or would you stick on to one over the other? And next is the PrEP adherence. So how is PrEP adherence measured in these 2 different dosing regimen and how are they different? The 3 is that we develop an app to help people to improve their PrEP adherence. So the first study on switches between dosing regimen, we use data from the 3 sites. So these 3 sites are in the clinical or hospital setting where doctors there prescribe PrEP. So you can see that initially, people at their first visit, 56% of people are on ED dosing regimen and 44% are on daily. And throughout the follow-up period, there are switches. There are switches from daily to event-driven and event-driven to daily and back to one and the other. And there are even people who switch more than 5 times. At the last visit, we're seeing 48% of event-driven users and 51% are daily users. So you can see that people do switch in our cohort. If we compare to other studies that reported event-driven and daily dosing regimen and also switches, the numbers are quite similar. So we're seeing the substantial proportion of MSM PrEP users actually switch dosing between daily and event-driven PrEP during the follow-up period. And it's very similar to studies, especially in European and African countries. We also look at factors that are associated with event-driven dosing regimen in real-world data. So it's showing that, as you can probably imagine, that people who have fewer sex are more likely to use event-driven. We also see that people with previous PEP experiences are more likely to use event-driven. Next, Joyce and I work on PrEP adherence. So with all this switching and different dosing regimen, how do we look at PrEP adherence here? So in the literature, there are a few ways to measure PrEP adherence, and a lot of them, most of them have their pros and cons. For example, the most commonly used is the self-reported survey. We often ask them like the condom used during the last anal sex. So this method is, although very easy to use, but it might have problem of recall bias. The second one is an objective measurement that we measure the drug concentrations in hair and or dry blood spots. It is, however, costly and time consuming. And in many countries, such as in Taiwan, we don't have people to actually do this for us. And the third one would be white pill bottle openings. This is a method that sometimes you will underestimate PrEP adherence if people are not using a bottle. The last one, mobile app, where you can log your PrEP use, is actually quite similar to this white pill bottle openings, that if you don't use it, then we underestimate it. But there's good things about this method, because if we think of event-driven dosing regimen, if you don't have sex, you actually don't need to take PrEP. So we actually need people to log their sex. So this is a method that allows logging PrEP use and sex diary. So those are like different ways to measure PrEP adherence in the literature. What we did is using the data. One is using the data from the 3 sites. And if we look at PrEP adherence among the daily users, across studies on that, as you can imagine, that subjective measurements are reported much higher number than objective measurements across countries and studies. So people usually tend to overestimate their own PrEP adherence. And our data from the 3 sites here, similar to the rest of the studies, falls within the range between 80 to 90% for the daily dosing regimen. And for the event-driven dosing regimen, our subjective measurement showed 81.8%. It's lower than our daily regimen, but this self-reported data was not too low compared to other countries. However, this is the data that we will talk a little bit later. So this is data from the app we developed to help people monitor their sex and pill taking behavior. Subjective measurement of PrEP adherence is actually quite low. It was only 62.4%. Which pills are people missing if they are taking event-driven PrEP dosing regimen? We found that most of people, so you could be possibly missing the pre-sex pills or post-sex pill. So we found that the majority are missing the pre-pills. And if we look at the factors that are associated with PrEP adherence, in the first model, we included only PrEP dosing regimen, but not thinking about switchings. And we can show, as you can probably guess from our descriptive data, taking PrEP event-driven is negatively associated with PrEP adherence. But in the next model, interestingly, if we include switching into this model, we can see that regimen switch from daily to event-driven are the group that has lowest PrEP adherence. So now the event-driven dosing regimen is no longer significant if we consider switching into it, meaning that switching from daily to ED is a group that we should worry most. So switching to ED dosing regimen had lower adherence than daily users or users who never switch. Event-driven PrEP is more complex and technically demanding dosing regimen, but it's possible to be familiarized by users by repeating the regimen. And we also showed that not all participants choosing event-driven PrEP were capable of planning sexual intercourse in advance. That's why a lot of people are missing the pre-sex pills. So that leads us to our next study that we feel that we need some novel interventions to assist PrEP users in self-monitoring their PrEP adherence, especially considering there's so many people in Taiwan using event-driven dosing regimen. So this is our app. This is a novel mobile application designed with a user-centered approach. And it's really what's the difference between all the apps for PrEP adherence is that we really have event-driven dosing regimen in mind when we develop this. So this app allows flexibility for people's dynamic dosing choices and aims to improve PrEP adherence by sending reminders based on the current dosing regimen and users' sexual practices. So there are three major features. One is that you can record your PrEP intake, choice of dosing regimen, and information for each sex event. And we give you reminders for users who take PrEP based on their dosing regimen and their pre-arranged date for sex, so that to monitor. And we also monitor their PrEP adherence. We also track whether users' sex events were protected by PrEP and log their dynamic PrEP dosing choices. This is from our pilot study data. We're showing that 22% of sex events on the app are not protected by condoms. 22% were using condoms. So why is this topic an interesting or important topic in Taiwan? Is because in the future, we're going to introduce so many different kinds of PrEP in the market. So there's going to be long-acting injectables. There's also going to be other forms of other forms of oral PrEP. So people might be switching between different dosing regimen, which requires behavior scientists to be more creative to adapt to people's PrEP taking behavior. And thank you very much. And let's move on to our next speaker.
Hi, everyone. Hi, thank you for having me. My name is Isaac Chu, and I'm a postdoctoral research fellow at London School of Hygiene and Tropical Medicine, joining you from London. So apology if I start mumbling because it's like 2:30 a.m. here. But I'm very, very excited to have the opportunity to join you at Kirby and to talk about another perspective of PrEP implementation in Taiwan, which is a PrEP prescribing by providers. So let's investigate the unmet need of Taiwanese community-based physicians for prescribing together. So first of all, I think it's important to talk about the context. So let's talk about the context of Taiwan's national health insurance. And it's just like Australia's Medicare and UK's NHS. Taiwan established its universal healthcare national health insurance, NHI, since 1994, and is the biggest single insurer to reimburse the majority of provider and users. And a provider that consists like 4 levels, work at medical center, regional, district hospital, and clinic. And the majority are private, 98% clinic and 84% of hospital are private owned, and famously or infamously, like lots of healthcare provider at hospital are overworking. So really thank lots of Dr. Stephane joining us today among his busiest timing. And in short, as if you are Taiwanese, and if you just have your NHI card, you can just pay quite really affordable co-payment lasting from 2 to 3 Australian dollar per time at clinic, or to 25 Australian dollar at hospitals. So you can access all kind of hospital facilities. There's no restriction on accessing different levels. So you can see our referral system can be understood as a bit dysfunctional. On the right upper hand, you can find people like queuing up for getting their prescription. And right lower picture, it shows like the high street can find different kind of specialty-based clinic within 8 clinics within 300-meter walks. So it's kind of dysfunctional and not really connecting very well. And in terms of sexual health, unlike Australia, which you have sexual health center, or UK have gun clinic, we don't really have a designated specialty or premise for sexual health care. According to our CDC, patients with STI are very shy to access care. So since 2010, Taiwan CDC started this STI-friendly physician program. It's a certification, it's a training for physicians and allied healthcare workers to improve their STI counseling, diagnosis, and treatment. And this training includes PrEP training since 2017. And if you finish upon receiving certification, Taiwan CDC will list the name of physician online, so patients know where to go. And annually, like urology, dermatology, obstetricology, family medicine, which is similar to GP in Australia, and infectious disease societies commission to train physicians to obtain a certificate about STI-friendly physician. And physicians are the only legitimate PrEP provider in Taiwan. I know in Australia since 2019, all physicians and some nurses can do, but in Taiwan, there's still a gap for us to include the differentiated service delivery in terms of PrEP. In addition, there are additional challenges when we think about Taiwan's healthcare system and PrEP care. For example, the time-consuming nature of PrEP care, and also the consistent influx may challenge the logistic of clinic. And not to mention, I mentioned a bit about overworking. So provider has limited capacity and time allocation for additional services like PrEP prescribing. And for PrEP prescribing and optimal PrEP provider, the literature talk about purview paradox, which is like HIV specialists may not really see HIV negative individuals and with the existing workload on HIV care, but primary care provider, they may be unfamiliar with PrEP and they may be uncomfortable to take patients' sexual history. So here we think about who could be the potential optimal PrEP provider. So we come up with the community-based STI-friendly physicians, CSTIPs. So CSTIPs, they are certificated STI-friendly physicians. So they see STI patients which at high risk of HIV, and that they are more competent in providing sexual health services because they have been trained and certificated. And they work at clinics, which they have, compared to hospital, there are more accessibility, more affordability, and more privacy. And if you may remember from Stephane's slide and the beautiful timeline, so here just quickly like recap about the wave of our Taiwan's government-led PrEP prescribing PrEP project. So the PrEP the first 1.0 is a demonstration project, and as Stephane mentioned, is partially subsidizing up to 105 PO per year, and it reaches like 302 individuals. And then since 2018, our government launched the national program, expanding to 38 facilities, and the government, like together with farmers, like voluntary donation of 2,000 person years pill, it reached 2,176 individuals. And now it's a PrEP 3.0, which since 2021, 38 facilities. And you can, if you are a young population and serotypical codon and chemsex user since this year, you can be partially subsidized or fully subsidized. And our government fully subsidized female users and in serotypical codon relationship. And for now, as the data this February, there are about 1,700 people. So if we look at the PrEP 2.0, which I just showed in a figure in the table, and you can see like only from this figure, only 2 are providing government-funded PrEP, which is the fundamental of Taiwan's PrEP implementation. 13 provide self-pay. And when it comes to now, the PrEP 3.0 version, only 3 CSTIPs, which we believe is the optimal provider, deliver PrEP to those who can benefit from it. So our question is like, why did few CSTIPs prescribe PrEP during Taiwan's national program? And I particularly focus on the PrEP 2.0, the first nationwide program. So to understand prescribing behavior, here we apply like a behavior change theory, which is a COMBI and theoretical domains framework. And the overall, you can see the wheel here, behavior change wheel developed by Mickey et al. At UCL. So as you can see from the inner circle, for any behavior to happen, it requires like 3 pillars. They may argue that it requires capability, opportunity, and motivation. And then if you look at this yellow ring, it's the theoretical domain framework, TDF, which delineated the sub-details of capability, opportunity, and motivation with 14 domains. And it can further links to design intervention and policy. For example, if we found that physicians or providers are unaware of PrEP, that can be coded as knowledge in the TDF, and it further links to the need as they may lack psychological capability. So we can try to educate providers to meet their needs for PrEP prescribing. If they're concerned about cost, then we can consider to change the environment by restrict the price or by enable the providers to think about making their ends meet. And these studies, overall study comprises 3 stages, and we analyze 48 documents and conduct 20 interviews. The first stage is qualitative exploration, and then we use the qualitative exploration to inform the survey, which is the theory-informed survey, together with the TDF and the Combi model. And last but not least, we administer the survey to all STIPs, all sexual health STI-friendly physicians, between September to November 2021, and we aim to understand what kind of needs need to be prioritized to inform our intervention for increasing PrEP prescribing among C-STIPs. So here are the findings. So there are so many findings, but I'm just, because of limited time, I'm just going to highlight, if you may remember, capability, opportunity, and motivation. I'm going to highlight opportunity and motivation, which is less covered by existing literature. For example, some CCs, historically, we realize that CC-STIPs, these physicians, they are not incorporated in Taiwan's centralized HIV care system. And operationally, some of these physicians, they lack HIV testing tool at their clinic, and they perceive that the financial impact of PrEP procurement, because there's only a patent PrEP in Taiwan, is really, really high. It's like 16 Australian dollar per pill at least. So it's really high to increase the procurement cost. And clinically, the time constraint and perceived low demand is there. So one non-prescribers say, we cannot see very few patients and spend lots of time in educating each patient. PrEP service takes time, and there are no corresponding benefit by taking so much time. Also, we also identify the missed opportunity by highlighting the challenge in the social influences. So during 2018 to 2020, the PrEP has been collided with the diverse value and prejudice during a heated debate in Taiwan about legalization of same-sex marriage. We had a referendum in 2018. And at that moment, anti-LGBT group, they just portrayed a negative norm, spread a negative norm, disinformation of PrEP by seeing it as a hookup pill. And the norm, this kind of norm has happened to be reinforced by also because most of our promotional materials highlights the needs of MSM and GBMSM for PrEP use. So it's just the link between PrEP and the negative image has been strengthened. And this leads to the intersectional stigma, multifaceted stigma in Taiwan about PrEP. So the PrEP stigma in Taiwan is intertwined with stigma of HIV, stigma of polygamous sexual relationship, and stigma of MSM. So for example, C-STIPs may avoid taking sexual history because they don't want to risk their relationship with patient. Let's look at this non-prescriber. They say, I learned at school that I cannot actively ask sexual questions because everyone's feeling is different. If you ask them questions, they may be annoyed and they say, are you saying I'm a promiscuous person? We Orientals, you cannot actively ask sexual questions unless they say yes. So this is a perceived sexual stigma there. And also the C-STIPs may find it very difficult to persuade other healthcare workers working at their clinics. One prescriber mentioned, I feel there's no way to solve the problem because some nurses are unwilling to take blood samples. They worry that if the PrEP users is an HIV patient at their clinic, even though the HIV status is not defined, right? But they can have a risk of HIV and it affects nurses' willingness to work. In terms of motivation, there are lots of lacking. And I want to spotlight these three things. The first one is professional roles and identity. So firstly, physicians may cross their perceived professional boundary between different specialty to break the purview paradox in order to prescribe PrEP. Look at this prescriber mentioned, because we are not PrEP professionals. I ask infectious disease specialists everywhere. I felt that I was not above to ask questions. Indeed, they know. They means infectious disease physicians know PrEP way more than us as urologists. Yes, we are going to eat their field. In Mandarin, that means like we are going to encroach the territory of infectious disease physicians. Interestingly, the other providers showed a totally different professional role when their personal prejudice override their professional roles. Look at this script. It's about when these MSM client comes to me, I will persuade them not to use PrEP. They should not use PrEP again in the future. This is my endeavor. I wish PrEP could just disappear because it's more aligned with my morale. Secondly, not taking PrEP means the commitment to take care of our body. There are still risks of HIV after taking PrEP, right? So this prescriber, even though he or she is a prescriber, the personal prejudice override the professional code. And despite that, we already include PrEP in our national guidance since 2016 and then 2018. And some physicians may feel pessimistic about the impact of sustainability of the PrEP program. Look at this prescriber mentioned that when the program ends, users need to rely on themselves. And in their opinion, they will slip back in their old ways. Users won't think I need to actively to do this of prevention. And the other talk about the reinforcement, which like they perceive PrEP and joining national program, government funding program, receive little or no return on investment. This one mentioned like medical care is for making profit, but you can save others when you are making money. So suppose you do this as a philanthropic act by spending so much time in administrative work and education, I reckon it's impossible to promote PrEP in this. In Taiwan, 99% of this prescriber may stressed will never do it. So these are all kind of different barriers, or here I portray as prescribing needs among physicians. So understanding all these kind of different needs, we developed a survey, and by using this strategy, we have a survey committee, and then we generate a construct based on the previous qualitative analysis, the COM-B and TDF model. We create items, we test doing cognitive interview, and we pilot, and then we administer the survey. So this survey have 4 sections covering 52 items in traditional Chinese informed by the theoretical domain framework. We define key unmet needs as domain to which more than 50% responded answer agree or strongly agree, and the survey was distributed between August and October 2021. So our findings of the survey, which is a quantitative part of the study, shows that first of all, the response rate at 16%, we cover like a 47% practice outside hospital, because the population is the total STIP, STI-friendly physicians in Taiwan. If we look at their awareness or experience, only 14%, 1/4 were unaware of PrEP. And around half of them feel incompetent at PrEP prescribing, and the majority of them never prescribed PrEP. And when it comes to PrEP modality, although they're aware of PrEP, 86% aware of PrEP, 42% didn't know about daily PrEP, and 50% didn't know about event-driven PrEP, which has been both adopted by our Taiwan's guideline before this survey. And if we highlight what are the key needs, so the top 2 key needs you can see here are that they require 86% require standard operating procedure tailored to physicians, and 85% require clinical support from non-physician professionals. So based on the qualitative and quantitative finding, we argue that there is a need to build an epistemic PrEP community, which means like epistemic community was referred to a group of expertise which in a specific field sharing the expertise knowledge. I would argue that all kinds of different stakeholders need to be joining these coalitions to improve the PrEP prescribing, including the Taiwan CDC, who founds the government program, including the medical society who trains these physicians, and the local council, local bureau, and a society who developed the guideline, the pharma who previously donate a free donation to our PrEP pill, and the user who need to up management their PrEP physicians. And last but not least, the coalition between PrEP physicians need to expand from ID specialists to C-STIPs who can consult and support each other. So the summary of this finding is like the COMBIV TDF model is applicable to identify the prescribing need. And for our quantitative part, most Taiwanese sexual health physicians require SOP and interprofessional support for their PrEP delivery. And we argue that engaging C-STIPs in Taiwan's PrEP care continuum can increase availability and create an inclusive PrEP epistemic community for upscaling PrEP implementation in Taiwan. So this study, as a part of the overall of my doctoral thesis, I would like to express my thank you to all co-authors here. You can see all the speakers here, and also Hui Jun from Kirby, and also Adam Bourne from both Kirby and La Trobe and all medical societies. And if I may still have 1 minute, this is our overall take-home message after you listen to our 3 presentations today. Firstly, we reflected on the whole picture of Taiwan's PrEP implementation from 3 key puzzles. You have understood user side, provider side, and overall policy programming. Despite Taiwan's multi-modal PrEP implementation, the high cost of PrEP due to the patent issue and limited service provision and intersectional PrEP stigma impede our PrEP scale-up. And the lesson learned from the stepwise program and the use provision of oral PrEP can inform a better rollout of next generation HIV prevention products. Thank you. And we look forward to your Q&A.
Well, thank you very much, Stephane, Carol, and Isaac, for those great presentations. That was very interesting, and there's some really, I think, particular things about PrEP in Taiwan in terms of how it's provided and how people are using it. So that was very interesting. We don't have many questions yet in the Q&A, so I would encourage everyone in the audience to please submit a question. But we do have some, and we're going to kick off with those. So I think, Stephane, you were going to respond first of all to Curtis.
Yes, from Curtis, I think he was wondering if we can have a simplified way to explain or to teach people to using daily PrEP and on-demand PrEP, especially with the 211, the first precoital loading dose. I think this is a very interesting question. Actually, we have been very troubled by teaching people how to do ED PrEP and daily PrEP, especially when that time we only have very limited data on GBSM who will be eligible for taking ED PrEP at that time. But now I think WHO had changed the guideline and they revised it earlier this summer. So now they are starting to recommend ED PrEP to anybody, to any individual who are born male in gender and not taking female estrogen hormone replacement therapy. So I would say that there might be a more simplified way to teach or to tell the community about ED PrEP or extended ED to daily PrEP with a loading of 2 pills in the future. But also in Taiwan, we're also drafting our new guidelines. So we're also trying to make it look more simpler. So hopefully we'll come up with some new ideas or even some new video clips to do that.
And Stephane, I think you were also going to, first of all, respond to Curtis's second question. Perhaps you could just briefly summarize the question before you do that. And Carol, I think you were going to add in relation to the second question from Curtis.
Yeah, I think when we do the instructional videos, we didn't really do a pre-test and after-test for tests, but we kind of, and also back that time, there are not so many videos from around the world doing on-demand contests. So we kind of focus on the regimen. You see the 211 thing, and also how you do extended one if you need if you're having more sex during the time. And also we are very emphasize on only a certain, most people like the almost all general population can take daily PrEP, and only with if you fulfilling several criteria, and then you can take on demand. So we make it kind of exceptional thing for for a very specified population. So that's how we try to focus on in that particular video.
Right. I just want to add that it's we appreciate this important question. I think it's a good idea. I think I remember seeing some papers regarding checking whether the knowledge of event-driven regimen was correctly delivered and practiced in the population. And I think it's I think one of the papers is from your university, and I think it's always a good idea to check. So probably in the future we'll do that.
The next question is from Barbara Jung, who asks what the rationale was behind the government funding for PrEP for people aged 35 and over, and under, but not for older people. So, which of you would like to respond to that?
I will jump to that because I feel that I'm so deprived of having a publicly funded PrEP in my country because I'm 42. So, well, it's always a very important and very interesting question. I think when CDC was proposing this and discussed this with the experts, and we are kind of very shocked about that, but they do have very limited budget. So they really want to have all the bullet to really keep population who might had the most impact on the epidemic. So I didn't really mention that in detail. That the epidemic is mostly driven by young MS and GPMC, and also from the cost side, because CDC and also the National Health Insurance is also paying for the HIV medication. So they simply think if we can prevent younger generation from having HIV and being treated for the rest of their life, probably will be most cost saving. And also for the younger MSM, they tend to have lower rate of testing. So they might not know their status well. So that's why this is also the reason that if they're being included or attracted to the PrEP program, they will be able to be tested frequently.
Okay, thanks, Stephane. Isaac or Carol, do you have anything to add, Isaac?
Yeah, sorry. I think I just want to add, like, because also I think one of the reasons is because the age stratum Taiwan CDC used to for the HIV incidence, I think the highest is like always like 25 to 34. So I think under 35 is literally like to focus on this population which disproportionately affected by HIV.
Okay, we do have one final question from Tyson, and I'll get onto that in a moment. But what I had one question, and it was related to this issue. And I think, Stephane, when you presented, you talked about the cost of PrEP, and I think you said that it is available significantly cheaper by importing generics. Is that right? So among people who don't meet this quite strict criteria for the CDC program, are there many people who are importing and using PrEP themselves?
Yes. So we don't have a very precise estimate from the numbers, but we do ask all the suppliers to submit their orders, like how many unique clients they have throughout the past few years. So so the first CDC program, they actually included around 26,000, 2,600 clients already. And this is very precise estimate from them. But from the imported or online suppliers, it's around 3,000 something. So if you can still see, like a majority of people are having access to PrEP throughout the public funded program. But still, that those who will not be able to get that, they may have the information or have the access to see these PrEP friendly doctors and get this online.
Right. Okay, thanks, Stephane. So the final question, we do probably have time in case anyone wants to quickly put a question in Q&A. But Tyson, who is a colleague of Ben and mine in the HEP program here, a number of us here are studying implementation science, theory and methods. And I see that Tyson's question is about why, for you, Isaac, why, to help us understand your rationale for using the COM-B and theoretical domains framework for understanding the barriers experienced by healthcare providers when prescribing PrEP, and also were there any other suitable determinant frameworks or behaviour change models that you considered to use to structure the study?
Yeah, thank you, Philip, and thank you, Tyson. I think it's a really great question. So I think here, because my research inquiries look at the physician at individual level, like what are their needs. So I think it's important to identify an individual level model and look at either you call it barrier or facilitator or enable or disable. I call it as need, because physicians, they need capability, opportunity, and motivation, either of them, to prescribe PrEP. So because each actors, they do have their need. Users have our need, physicians have our need, nurses may have need, policymakers may have need. And if we look at an individual level, I would believe that COM-B and TDF is really good in looking at individual levels need. And where there are also other different level of implementation model. For example, some research before using CFIR, the Consolidated Framework for Implementation Research, which brings you more like the context, the process, the inner, outer, and a more like a comprehensive level. But here I only look at the individual level because I think this is good to have a spotlight focus. Of course, the implementation issue is always broad. So feel free to chat more by email, and yeah, because limited time. Thank you.
Yeah, no, that's great. Thank you very much, Isaac. We're almost to the end. I guess I just had one final question of my own, and it was probably for you, Carol. In the data you presented about dose adherence and missed doses, it was quite disturbing, I think, to see that a really high proportion, I think about 80% of people who had switched, missed the loading dose. But we know that the loading dose in PrEP, if you're doing event-driven, is very important. So was there any more information about reasons for why people miss the loading dose? Was it that they had sex too soon, or that they forgot, or what?
That's a great question. We haven't done a study on that, but our guess is that, for one, that those numbers are on people who are not adhere. So it's not everyone that's on even that's missing their pills. And for those who are missing their pre-pills, we think that they might have a hard time predicting when their sex will happen. But then also at the same time, they might be using other ways to protect themselves. For example, if their partner is U equals U, or if they're using condoms, and they might not need to be 100% adhere to the ED dosing regimen.
Great. Well, look, thank you everyone for joining us today. That was a great seminar, and thank you very much to Stephane, Carol, and Isaac. Thanks for staying up late. But that's it for the seminar today. Thank you.